a very warm welcome on behalf of the Indian Dental Association Chandigarh State Branch and the International College of Dentists Section 6, India, Nepal and Sri Lanka. I welcome you to this webinar series on dentistry during COVID-19. And while we are starting with our webinar series, this is the first webinar session, and we have our esteemed guest today, the chief guest, Dr. Anil Kohli, and also the guest speaker of the day, Professor Ajay Logani from CDER-AIIMS, New Delhi. And without taking any time further, I am welcoming Dr. R.P. Gupta, the president of Indian Dental Association Chandigarh State Branch, as well as the International College of Dentists Section 6 for his welcome remarks. So, Professor Gupta, Dr. Gupta.
Yes. Hello to everyone, wherever you are. Good noon and welcome to everyone in this webinar on endodontics COVID-19. Padam Bhushan, Dr. Anil Kohli, our chief guest of today's webinar, Professor Ajay Logani, guest speaker, our professional colleagues, ladies and gentlemen. It is our pleasure to extend a cheerful welcome to Padam Bhushan Dr. Anil Kohli, former President, Dental Council of India. Dr. Kohli is a well-known personality in the field of dentistry with a great leadership quality. Always smiling, a versatile person, and endodontist of a national repute. He is a director of the vast multi-specialty dental center, the most famous one in New Delhi, by the name Dr. Soni Dental Center at Lajpat Nagar, New Delhi. Sir, I will take 1 minute. Why the name Dr. Soni Dental Clinic? It is Dr. Soni.
He was my mentor.
Yeah, he passed his legacy to Dr. Kohli. And Dr. Soni, he was a medical personnel and he did DDS in USA and started practice in Delhi. Previous ex-vice chancellors, even independence period, presidents, etc., any officer, they were their dental patients to Dr. He was practicing previously at Jorbag, if I'm not wrong. Sir, I visited his clinic at Jorbag.
Golf links.
And he used to have always eye coming out from
window. Audio jato.
Because seeing his work and everything and seeing his old age, he passed his whole legacy to Dr. Kohli. That is why. And he's still using the word, Dr. Kohli, Dr. Soni Dental Clinic. And he's organizing a oration lecture. Dr. Kohli is organizing in his memory in our every ICD installation function. Thank you. Dr. Kohli had been honorary dental surgeon to former President and former Prime Minister of India. Sir, we are all delighted to have you here at a very short notice, and that too out of your busy schedule. We are all very delighted to extend wholehearted welcome to Professor Logani, Head of the Department of Conservative Dentistry and Endodontics, Center of Dental Education and Research, All Institute of Medical Science, New Delhi. He is an eminent endodontist, highly knowledgeable, having vast experience, and most sought after speaker. He shall be covering how to manage the endodontic emergency during COVID-19 epidemic. Dear sir, we all convey our gratitude to Professor Logani for accepting our invitation in such a short notice and short call. Thank you so much, sir.
Thank you.
We all extend a warm welcome to the audience and the viewers who are from Pan India. We are obliged to each and everyone for participating in this webinar. Today's topic on this webinar is a little different than the usual one, but it is the need of the hour. And I'm sure that all you shall come out much wiser and knowledgeable to manage the endodontic emergencies during this grave situation of pandemic COVID-19. We also want to convey our message to the youngsters today, not to be disheartened. Instead, widen your knowledge and use this time to emerge out as a more stronger dentist who is well equipped to take all emergencies. Dear friends, today all strata of the society, be it the traders, manufacturers, professionals, etc., they are facing a crisis. Indeed, this calamity will come to an end in a matter of a time. We as a dental professionals are unique and not comparable to others. Let us help our patients in pain and agony and master the skills of perfect seamless dentistry. I will suggest be regular with CDE programs, enhance your knowledge and believe in yourself. Success will touch your feet. At this time, because the period is going, our youngsters are feeling down. I remember one word by my mentor, Dr. B.R. Watcher. When I was second year student, he took our one class and he labeled that dentists are aristocrats. He used to call us, we are one of the aristocrat population of this country. Then he defined what is aristocracy. He says, less work, more money. You charge, and at that time, the medical people used to charge a fees of rupees 5 rupees or so. And at that time, the dentist used to charge around 100 rupees or something like that. This was the difference. Even why we are a different class, I want to stress. A medical people charge in lakhs of rupees at the terminal stage of the person. But we as a dentist, we charge lakhs of rupees while smiling patients, from the smiling patient. This is the difference between the two programs. Sir, dear friends, all strata of the society, be all traders. Yes, I have covered it. At the end, I would like to convey our heartfelt thanks to each and everyone and make this program a success. Jai Hind, sir.
Jai Hind.
Well, many thanks to Dr. R.P. Gupta. I invite Dr. Kohli for his remarks.
Good morning, friends. Thank you, Dr. Gupta, for your wonderful introduction, although it was not required. And I'm very happy to be amongst my colleagues. Before we move on to the topic, I would like to share something with my colleagues. And we have to understand, firstly, because we are at a crossroad right now, almost 3 months have passed. And COVID is not the first or the last epidemic which is spreading and causing disruption and death at large scale. We are in a very difficult and challenging times. Every day, new guidelines are coming. Every day, new webinars are coming. Now, even if you take today, an article in American Journal, and which is from the Center of Disease Control and Prevention, and it talks about the respirator 95. Then there's another article which talks about the PPEs. So, lot of research, lot of things have come up, but thanks to the social media, we are at a stage where so much of fear has been created in the society and in the common man's mind. Definitely, I don't disagree. Virus is deadly. We have to protect ourselves. We have to protect our workers, and we have to protect the human being, those who come for the treatment to us. But unfortunately, for last 3 months, absolutely dental clinics are closed because of the government guidelines and other things. And now, after the 4th lockdown, we are coming into the 5th one, and still the red zones are not being opened. It is at a very, very crucial juncture this webinar has been arranged. And today, the dental elements, there are certain things which are unavoidable. You cannot avoid and tell the patient to go back or not to do anything. Definitely taking all the precautions. We are not in a situation we can break our clinics and make them ventilator and we put them like this to make the air to come in and all those things. So we have to accept, first thing, that we have to live with COVID-19, number one. If we have to live with the COVID-19, we have to understand that we have to follow certain protocols. Now those protocols have to be failed and we have to make an arrangement and build the confidence of the patient so that they should not feel frightened coming to the dentist that this is going to be an infected area only. So this is a very important step. Now coming to the point, today we are with Professor Ajay Logani, who is the professor and head of the department of Endodontic Department of All India Institute of Medical Sciences, Prime Institution. He is the vice president of Indian Endodontic Society, which is the main body of endodontics. And All India Institute of Medical Sciences is the trendsetter because he is an academician, he is a clinician, and these are the people, those who are formulating guidelines for the people like us to follow as they have been advised by the Niti Aayog, by Ministry of Health and Welfare and Government of India. So with his vast experience for more than 25 years, Ajay Logani is going to share with us what are the things we should do, what are the things we should not do, what are the protocols we should follow, because ultimately these is a trendsetter. And life has to start. We are stand still. So we have to restart our journey as a professional journey, reset and restart again with proper protocol, proper precautions, proper history of the patient. And I am very delighted to be with him on this webinar. Let him finish up his talk and then we'll move on to the question answer. Thank you very much.
Yes, please. Thank you.
Thank you, Dr. Kohli, for such an inspiring address during this critical juncture. And with this, it is a privilege, indeed a privilege, to welcome Professor Ajay Logani.
I think we're done with it. We've done twice. I think we already 12:20 and we should start because then
30 seconds.
it's okay. Arpit, I think sir has said enough for me. Please don't mind, but I think the words coming out of respected sir Dr. Anil Kohli are sufficient for me, and it's been introduced very well couple of times, and thank you very much, sir. I'm actually honored to be sharing the same PPT slide with Dr. Anil Kohli. Maybe a dream for everybody who grew up in that era of the 90s and the 2000s, seeing Dr. Kohli do so much for the profession over years, and very happy to be invited by Dr. R.P. Gupta. He is the president of the Chandigarh IDA and the president of the International College of Dentists. And thank you very much, sir, for organizing this seminar. And Arpit. Arpit has been very, very close to us. He was with us at the All India Institute before he joined as an associate professor at the PGI, Chandigarh, where he's doing excellent work as far as community is concerned. And with those small, just welcome, I would start my presentation. And as I said to Dr. Kohli that maybe I would end, it's 12:20. Maybe 45 minutes, and I should be there by 1:05, and then maybe we can have some time for discussion. So thank you very much for everything, and we would start our presentation. And you've got to understand that the word which has been doing the world over, there is a hashtag is the word Corona. And it has been there. We started hearing on the 31st of December for the first time, but by the time it caught up with us, it was already January end, and we thought that we were going to be immune to it. We had planned some holidays in January, February. We thought that it's only going to be in China. It is not going to be affecting us at all, but frankly, we were a little wrong on that aspect. Um, it turned out to be the king virus. It turned out to be the king virus, and we know why is it called corona, because of the crown-like structure which they have found on to the virus, and they've called it as the SARS-CoV-2, and it is causing the COVID-19 disease, which is rampant all over the world. As of speaking now, India is actually facing a peak, and a lot of healthcare workers are getting affected by this. And I think the time is there when we all have to be careful. Since the COVID-19 has come, everything has changed. Believe me, everything has changed. The way we greet each other, the way we shop, the way we stand in a lift has changed. Everything has changed. The way we used to take our seminars, I mean, it was, I think the present generation would never ever have that confidence of sitting in a room together and listening on a live speaker. Everything has changed into a webinar, and that is why where we are here today. And maybe some advantages, because if you see these kind of things, at least social distancing is being maintained, and we are sitting in a safe place at our home and speaking to each other and sharing knowledge. Obviously, not only has it changed the way our life, our classes, but obviously it has also changed the way we are practicing dentistry. A doctor's coat, a 3-ply mask, and a glove was what was seemed to be sufficient enough pre-COVID era, I would say the pre-25th March era. And suddenly after the 25th of March, we were thrust in with guidelines which were asking us to wear every type of protective gear. What I would prefer to call it as a quatch, because it was told to that it would protect us, and that is what we started to wear it post 25th of March. But some things never change, and if I show you the next slide, some things never change in life. We've seen this man, I had black hair when I first saw him, and I've grayed, we're still seeing him. So some things in life would probably remain, and we hope good for him and his health. But as far as dentistry is also concerned, may everything change in dentistry. One thing which is not going to change in dentistry or specific to endodontics is endodontic emergencies. This is here to stay. So since the lockdown period, which happened on the 25th, the 22nd was the Janta lockdown. So at the All India Institute of Medical Sciences, we were started to feel that from the 19th and the 20th of March, that the number of patients which we would be seeing over the next lockdown period would be less. But something which was very, very surprising as far as the Department of Conservative Dentistry and Endodontics at the Dental Center at AIIMS experienced was the same number of emergencies. So I'm just trying to put across a pre-COVID area and a post-COVID area, or rather would say that the era which is still continuing. If we were receiving 6 to 7 emergencies in the endodontic department pre-25th, we ended up still having the same amount of emergencies during the lockdown period. The only thing which was changing is the way we were sitting. So 4 to 5 emergencies pre-COVID area, the same number of endodontic emergencies after the lockdown period. Proudly, I need to tell you is that since the country went under a lockdown from the 25th of March till the 31st, which is this date, the CDR endodontists have been actually the frontline dental warriors. Yes, all the other specialties are functioning, but we do realize that there are 2 main specialties which kept looking at emergencies. One was the endodontic department, and obviously the oral maxillofacial surgery people had their set of emergencies which were being looked at. Over the last 66, 67 days, we've had provided 400 consultations, teleconsultations. Just to highlight that these teleconsultations were for the patients who were undergoing the treatment before the sudden lockdown period occur. So what we did was we called up all those patients who were undergoing treatment pre-25th of March and asked them if they were experiencing any problems. And just in case we could solve their problem over the teleconsultation, we tried doing that. These were the major of the patients who were already undergoing treatment before the sudden lockdown occurred. Once the patients kept creeping in, and during the lockdown period, we had approximately the number of patients who were being attended were around about 267 patients, which got attended during the lockdown period at the Department of Endodontics. And if you see this graph, the phase 1 of the lockdown had really less number of patients, because probably the patients didn't realize that how long the lockdown period is going to be there. And by the time the second lockdown was announced, probably the number of patients with emergencies had to visit the endodontic department. And no doubt there was a gradual fall in the phase 3 of the lockdown, but the number of patients have kept increasing as far as the fourth lockdown period is concerned. And probably this is what Dr. Kohli was trying to say: how long can we make our patients sit at home and with pain, was what was being getting reflected here. Out of all the patients which we attended in the Department of Endodontics, 117 were emergencies. Now from this slide onwards, for the next 10 slides, I have a point of view which I would try my level best to get across the message. I am trying to tell here is that out of the 247 odd patients which we saw in the Department of Endodontics during this lockdown period, 117 were endodontic emergencies. And if you see, 80% of those cases were symptomatic irreversible pulpitis with symptomatic apical periodontitis. So that the pulp was vital in those cases. We had approximately 18% of the cases which had pulp necrosis and acute apical abscess or cellulitis. And if you see this figure, very interesting, the trauma cases dropped. So this is something which has changed in the post-COVID area as far as AIIMS experience is concerned. The number of emergencies, the top 2 emergencies were almost similar as the pre-COVID area, but the number of trauma cases. Now, this is quite very explainable because we had a lockdown. There was no road traffic accident happening. So the dental trauma decreased. And I think the alcohol fueled trauma, which is a terminology, was also less because everything was shut down. So maybe these were the 2 reasons where we saw the number of trauma cases going down, but as far as the other emergencies remaining stable. As far as the non-emergency cases, which were the rest 130, which we saw in our department, were fractured class 2 restoration, class 2 cavities were the non-emergencies. So these were almost 130 patients. One thing again, which we saw something surprising, reporting to the Department of Endodontics was almost 5% of the cases had ulcers and painful ulcers. So the patient could not appreciate what was the cause for the pain, but so since it was a pain, it was referred to our department, and we saw almost 6 or 7 cases out of those 130 cases of non-emergency, and almost a lot of them were ulcers. But majorly, they were class 2 restoration, which was almost like an urgency for a patient. As far as the number of procedures which we carried out, and I would like to highlight here is that when I say number of procedures, it is the aerosol generating procedures, which we carried out at our dental center in the division of conservative and endodontics. Non-surgical endodontic therapy was done in 96 of the cases, vital pulp therapy in 18, that is pulpotomy, and obviously the traumatic dental injury had to be treated the way deemed fit. Maybe it's splinting, immediate splinting, or pulpectomy, which was done in these cases. So the number of procedures, which were 117, were aerosol generating procedures. As far as the management of the non-emergency cases were concerned, we did almost 100 non-aerosol generating procedures. That is, if a patient had a fractured restoration or a new class 2 cavity, if we could manage it with simple excavation and give an IRM dressing there, that was it. But the other were consultation. So what particular consultation we did, our experience was, we asked, so as I explained to you, the major of the problems were class 2 cavities. And if we could not do a non-aerosol generating procedure in them and do an IRM in that, we advised our patients to keep that area clean by using an interdental brush. And after every meal, this something which we also advised them was to dip the interdental brush in either betadine or chlorhexidine and keep that class 2 or a class 2 proximal area clean, free of debris, so the chances of them to have pain would be reduced. So we tried doing the non-aerosols, but the ones whom we could not, because maybe they were larger, we needed to modify the cavity. We just told them, maintain your oral hygiene by doing an interdental brush, dipped in betadine or oral hygiene, so some amount of antiseptic could reach that proximal area. Based on this kind of experience of almost 247 patients, this is what our presentation is going to be based in the next 25 to 30 minutes. And that is what I would like to share with you. Why is this slide? Because this is our personal experience. Obviously, our experience is based on evidence. Our experience is based on our AIIMS guidelines and our own understanding of the literature. And that is why I say that let it be a disclaimer as far as the things which we are going to be showing or what we practiced in these 2 months may be debatable, but we've tried doing it at the level of evidence, certain amount of evidence, and obviously not throwing to air any of the guidelines which were given to by our own institute. The next 4 or 5 slides is something which may be questionable to a lot of people, but I would try and explain why I wanted to speak on these aspects of the slides which I am going to be presenting. The first thing which I need to highlight here for everybody is you have to differentiate between an endodontic emergency and an endodontic urgency. Guys, the next 4 or 5 slides are having a message for everything. The rest of the slides are going to be more of pictorial. So please concentrate on a point of view which I'm trying to highlight here is we guys have to understand what is an emergency, an endodontic emergency versus an endodontic urgency. It is absolutely simple. You can do it over the telephone. You can ask the patient in front of you these 3 simple questions and you will know what the emergency or an urgency is. The first question is this on your slide. If the patient says that my pain has been there for 24 to 48 hours, is the answer for the first question. If the answer to the second question is yes, I am unable to sleep in the night because of the pain. And if the answer for the third question is that, look, doc, I have taken my medications. I have taken Combiflam, I have taken acetaminophen, I have taken Ketorol, I have taken Proxicam, but my pain is only getting relief for 2 hours and it is coming back. So if the answers for this is what I told you, then yes, you are dealing with a true emergency. If the patient is having a severe pain for 24 to 48 hours, can't sleep in the night because of the pain, his painkillers are not relieving his pain, then guys, we are dealing with a true emergency. And a true emergency, I don't know whether you can see my slides on the right side because I think the pictures are getting, PIP is getting shared on that also. So if you can remove it, as far as an emergency in endodontic is concerned, if you have that smiley face between 7 and 10, which says severe or unbearable pain, is what we constitute as a immediate emergency, a true emergency, and you have to intervene immediately. There is no question. There is no question if the patient on a VAS score says my pain scale is between 7 and 10, there is no question of doing anything else except intervention. And as far as the non-urgency is concerned, if you have a smiley face between 4 and 6, yes, it is less severe. The patient is experiencing moderate pain and you can do some pharmacotherapy and schedule an appointment. Now, up till this slide, I tried explaining you what is emergency and urgency. And I tried telling you how do you measure it on a VAS score. The smiley scores are there. This was what we were following before the 25th of March. What happened after the 25th? So let me just tell you again that these are 3 endodontic emergencies. So just set in your mind that these are 3 endodontic emergencies. Irreversible pulpitis with or without symptomatic apical periodontitis, acute apical abscess or cellulitis, traumatic dental injuries. All these 3, these are the only 3 endodontic emergencies which you need to look at immediately. And we were looking at these emergencies pre-25th. If a patient came with any of these 3 emergencies, whether we had time or not, we used to schedule them. And I'm sure this was the situation in the practice also. If you see any of these cases in your practice, you would make one of your patients sit down and treat these patients because these were true emergencies. But these were pre-COVID area. What changed after 25th of March were the guidelines. The guidelines told us that we would divide our emergencies into life-threatening and non-life-threatening emergencies. And all the true endodontic emergencies, which I explained it to you, were clubbed under urgency. And not only did our guidelines club them under urgency, so it's not our guidelines. If you go on to see the international literature, they also club the pre-COVID emergencies, which were irreversible pulpitis, pulp necrosis, or trauma. They clubbed it under urgency. Pre-COVID area, we were only told that we have to intervene immediately. But the post-COVID era, that is the 25th March, they broke down it to be a primary management and a secondary management. So please try and look at your screen, which has yellow marks. So if you had a patient of irreversible pulpitis in before 25th of March, what would you have done? You would have immediately intervened and done a root canal access opening. But if a patient came to you post 25th, so something changed in 24 hours, what you were supposed to do according to evidence base and according to our guidelines was to have a primary management line and a secondary management line. And the primary management line was send your patient back with painkillers. If the painkillers didn't work, give him dexamethasone. If the dexamethasone doesn't work, just give him a long-acting local anesthetic. And if in case these things didn't work, go ahead and do endodontic intervention. I hope I'm trying to get my point of view clear. So go back to the evidence which was given us in 2017. It clearly said that no analgesics work in a case of irreversible pulpitis. No analgesics work in a case of irreversible pulpitis. The maximum relief you can get is by injecting intramuscular with a Voveron injection, which can give you some relief. You can take ibuprofen, you could take acetaminophen up to 1,000 milligrams. It would give you some relief up to 2 to 3 hours. It is clearly highlighted on the red mark, which I have tried to say. So the bottom line is no analgesics work in irreversible pulpitis. The second bottom line is the highest level of evidence says that no antibiotics works in irreversible pulpitis. The third evidence says we have no evidence. Frankly, as far as what the JOE has been telling us that, look, give analgesics, it doesn't work. The evidence tells us high level of evidence. Give antibiotics, they don't tell us that, but a lot of dentists in India, abroad, everybody gives antibiotics. That is why we have a level of evidence that antibiotics also don't work. They've gone on to tell us that give somebody steroids. So the JOE article tells us to give a 0.7 to 0.9 milligrams per body weight. Our own guidelines from our society says 4 milligrams, but frankly, if you go deep into the literature, there is no evidence which suggests that dexamethasone works. These articles which are getting quoted in the literature and in the guidelines are actually meaning that you do an endodontic intervention, and in addition to that, you provide the patient with a steroid. But what in the primary guidelines, which we are doing, is just providing analgesics, just providing dexamethasone, and expecting that the patient's pain is going to go. Our experience, we tried doing that because that was given in the guidelines. So the first 10 days, when everything shut down suddenly, we tried doing that. And what happened? We gave our patients antibiotics, we gave our patient painkillers, we gave our patients steroids. And what happened was that the 50 to 60, rather 70% of the patients reported back with severe pain. So what did we do? We exposed ourselves to that patient in the first appointment, just wrote medications to that patient and sent that patient back. But that patient was back with us, howling in pain within 8 to 10 days after having finished his antibiotics. And what did we observe more? Sometimes an urgency. This patient was referred to from a private practitioner to us, where he was just being given medications for the last 15 days, antibiotics, painkillers, and everything. And he had to be admitted in the ENT for a case of Ludwig's angina, and an emergency tracheostomy had to be done. So my point of view here is very, very clear. Why, if a patient with an endodontic emergency comes, that's irreversible pulpitis or pulp necrosis, if you're trying to think or believe that we can solve the patient's problem by just giving analgesics and antibiotics or steroids, I think we were horribly, at least, going wrong in that direction. We had to intervene because, as I told you, our experience says most of the patients came back, and sometimes what we thought was a dental emergency became a life-threatening emergency. So I thought that changing the endodontic emergencies into an urgency parameter in the guidelines could have been looked into again. That is what our take was. For us, severe endodontic pain was true emergency, and that is how we wanted to treat these patients tactfully, efficiently, and safely. I would try and tell you why did I use these words in my presentation. So we started treating them. Obviously, everything needed some change. No major changes, as Dr. Kohli said. Obviously, private clinics would require a lot of infrastructural changes, would require money. We are not looking at doing that. In the government, it's not possible to do infrastructural changes in a day because we have almost, the file would take 3 months before it moves. So the message here is try and make use of what you have, but take your precautions. So we had a glass separating the lady in the reception. So that was there for them to be there. So that was protective enough. If you don't have, just get some kind of a barrier between a protection between the reception and your patients who are coming in. Obviously, it was a government mandate that we start displaying the etiquettes of cough and everything. So the posters started to get displayed in all the places in our field. Obviously, social distancing had to be done. So we reduced the number of chairs in our waiting hall. So the number of chairs had to be put at 6 feet distance. We have to follow them very, very carefully. We had to instruct all our patients to wear masks. And the government guidelines say if a patient does not come in a mask, we have to provide the mask to the patient. And if the patient still refuses to wear a mask, we get such patients at the All India Institute. There is a fine for patients not wearing a mask, especially in the healthcare sector. So that is what we did as far as our waiting hall is concerned. We just reduced the number of chairs, made sure that the patients are socially distanced. We made sure that they are having these things. Okay, no evidence onto all these things which we do, but if you go down to the south of India where I studied, we were told to remove our shoes before we entered the home or the clinics. I remember private practitioners in the 80s in Chennai having us to remove our shoes and then only going into the clinics. So this is an age-old thing. Shoes are going to be a source of infection, not necessarily virus. A very, very good habit to remove your shoes outside your area of clinics. So if people are, I'm sure in the south of India that practice is still there, but in the north of India, I do not think that number of patients are doing that. But if you are not doing it at this time, you are only trying to make sure that all loose ends are tied. And one of the loose ends could be that the shoe, one of the articles said that the shoe could be a carrier of the infection. So a good habit to remove your shoes. We started to provide them with shoe covers if we were unable to manage for every patient removing the shoes. Thermal scanners, yes, it is a guideline. So we were doing it. We are doing it for every patient who comes into our setup. The first thing is that we take a temperature. The only thing which you need to do here is that if a patient walks in, please make him wait for 10 to 15 minutes. Let him get into the ambient temperature before you take the temperature, because in this heat, when he walks into your clinic, he may have a raised temperature, which would give you a false alarm. The second thing which we have understood is that if a patient comes with cellulitis or abscess, there may be that he is afebrile because of the cellulitis and abscess. Now that is the role where you would have to come across your personal judgment. As the CDC says that an emergency, as far as is to be concerned, it has to be made from case to case basis. So just don't dismiss a patient with an abscess because he has fever, thinking that it is a COVID-19 fever. He may be afebrile because of the cellulitis and because of his abscess. You've got to make sure that the fever is of this origin and you've got to take him in. That is what it is. We started asking specific questions, and the main question which one of my colleagues pointed out to me yesterday, that what our department was doing is made mandatory for an Arogya Setu app to be downloaded by the patient before he came to our department, and only if the Arogya Setu app showed him to be a low risk or safe did we see him. Obviously, if he had an emergency, we went on to asking many more questions, but we made it mandatory at our department to at least have the Arogya Setu app downloaded for those patients. I think a doable thing for a lot of people at any scope of practice, maybe a single chair, multiple chair, Arogya app could be a very, very useful tool to be downloaded and for the patient's safety. Obviously, these normal questions of sore throat, fever, body ache, breathing difficulties have been asked. We asked them that, do you suspect that you've come in with? We were extremely careful with our own colleagues. Anybody who was working at an Indian Rotary Cancer Hospital or any of the hotbeds in the hospital, we were very, very careful in asking these questions, because over the last 10 days, we've understood that the healthcare workers are becoming the source of infection. So if you are treating any one of your colleagues, be very sure about these questions to them. The general population, we still are understanding, at least the government is understanding, that we may not have had a community spread right now. So if we can take our precautions, we can. The message here is that the HCWs are the ones who may become an area of concern. Are you coming from a hotspot or a containment zone? Yes, this had to be asked. The Arogya Setu app would also let us know. If the answers to any of these questions were yes, we were referring them to a COVID-19 testing facility. And if the answers were no, then only would we take them for our dental treatment. One thing which we did was to have a contact number and an alternate contact number for all the patients who did come into our facility. Patient hygiene, we were very, very particular, and I am very proudly telling you that not a single patient could enter the clinic without doing these basic steps of washing their hands, washing their face, and using an isopropyl alcohol, 70% isopropyl alcohol based hand rub. Once only did they do these things, did we allow them. As far as the triaging of the patients was concerned, it was only done by a consultant, because we personally feel that experience matters at this time, and triaging of the patients into an emergency or an urgency was done only with the help of a consultant. In our AIIMS terms, it was a level 1 PPE. A level 1 PPE is a gown, examination glove, an N95 mask, and a face shield is what we are defining at AIIMS as a level 1 PPE. And for consultation for all patients, all our consultants will be given a level 1 PPE. OPGs were the preferred choice of X-rays, but we did not shun ourselves from IOPS if they were required. The only thing we did was to triple sheet our sensor. So the plastic sheet here on the left hand where the sensor was protected, then we just cut a glove of an examination glove, put that onto our sensor, and obviously the plastic sheets were there. So we had a triple protection as far as our sensors are concerned. And we tried taking all our X-rays with a paralleling technique. So we had the rinse sensors there so that just avoid, even if the patient had a cough reflex, we were far away from the patient. So these were, so OPG was preferred, but we never ever shunned away from taking an IOP X-ray, but obviously with precautions. And immediately the sensor had to be disinfected with isopropyl alcohol. There is no question of letting the sensor be used on another patient. We're doing that. The endodontic operatory was always prepared before the patient came in. All the contact areas which are within 3 feet, which cannot be protected, could be protected with the sheet which was coming in our kit. So we had all the areas where the patient was sitting, or the highly touched areas were covered with these kind of sheets. And the consultant told the resident, the senior resident, that which type of a case we would be doing. So all the armamentarium was ready before the patient came in. And that is what we did. As far as our doctors are concerned, as I said, we had guidelines from the institute. We had to follow them. We followed them, and because those guidelines have some meaning. And as far as the donning and doffing is concerned, it was a level 2 PPE. So what was the difference between a level 1 PPE is and the level 2 PPE is that this was a full body suit with a hood and obviously an N95 mask and a face shield, shoe covers, and examination gloves. Over that, surgical gloves was what we considered as a level 2 PPE. Very happy to hear you, to share with you that the All India Institute made a film, a short film on donning and doffing. I have given you the link on the left-hand side corner of the screen, and that it shows you exactly how to don this gown and how to doff this gown. And we had to label our guys, because once you wear these gowns, you cannot know who is in. Is it the chairside assistant? Highlight feature here is that the chairside assistant as well as the treating doctor had to be given the same kind of protective barrier. There was no discrimination of any sort as well, because if these were only when we were doing aerosol generation procedures. As far as the proper usage of mask is concerned, we had a lot of confusion in the start. A lot of doctors were recommending that wear a 3-ply mask and over that wear an N95 mask. Now that is absolutely wrong. So the whole concept of trying to save yourself because of the N95 mask is lost, because the seal is lost. So please do not wear your 3-ply mask below your N95. Then we started to wear our N95 down and the 3-ply mask up. But believe me that it was really causing a lot of hyperkalemia, in the sense the carbon dioxide content was really hitting your brain. And so the alertness level was going down when we tried doing this. My own personal experience, that whenever I tried wearing an N95 and on top of that 3-ply mask, it wasn't working. You were breathing very, very heavy. So for all practical purposes, just a single N95 mask is sufficient, even in an aerosol generation procedure. Please do not add or subtract anything out of this. Just an N95 is sufficient for us. As far as goggles and face shield is concerned, we had our own experience in this. Goggles were causing fogging. And when we were trying to do an endo, you do realize is all like searching about canals. Whenever this was being done, the fogging was a huge issue. And all these drawbacks, which I have mentioned in this, that it was very, very difficult to, claustrophobia was there. It was fogging was there. And the biggest advantage of wearing a face shield over goggles is that it prevents your N95 being soiled. So if you just wear a goggle and an N95, if there is a splash, it is immediately onto your N95. But since the screen covers your larger space, your N95 is getting protected. So maybe in our opinion, the face shield worked better for us as far as the goggles are concerned. And a few of our doctors really felt that if they were looking at working under magnification, it wasn't possible if you are wearing goggles, or if you have prescription spectacles, it is not possible to wear over them. So for us, it turned out to be that face shields were a better option as far as it's concerned. As far as the patient preparation is concerned, we went by the guidelines, but got to tell you this, that these guidelines do not have any evidence as far as either betadine or hydrogen peroxide being effective for SARS-CoV-2. But the articles which are being quoted are not for specific SARS-CoV-2. So we have no level of evidence, actually no evidence whether both of them are being effective against this. But as I said, don't leave anything to chance. These are very, very small things. In any way, they're going to get the bacterial load down. So no harm if you can just do a simple 1-minute gargle with betadine or hydrogen peroxide is good enough. Reassurance. Sir said that reassurance is something which we were really looking at. The patients were distraught this time because having to come down in a lockdown period to All India Institute, people thinking that this is a hotbed, they may get infected. Our doctors were thinking that they may get infected. So a reassurance was something which was very, very needed for these patients. Obviously, in any endodontic emergency, we were looking at profound anesthesia. But this time, we all know that anesthesia can get affected by the emotional component. We all knew that the emotional component was there playing a bigger role this time. So the reassurance had to be there. We had to tell our patients that we are going to take care of them. So we needed to spend a little more time with them, talking to them, obviously under the protection, but the emotional component was playing a big role. And obviously the pathophysiological component is always there. The reason because of the hot mandibular tooth or because of the irreversible pulpitis, those things were there. This is a guideline which was not changed pre-COVID or post-COVID. After local anesthesia, specifically in an irreversible pulpitis case, guys, wait for 15 minutes. 5 to 7 minutes of anesthesia in an inferior alveolar nerve block is only getting you to a soft tissue anesthesia. What you are looking at is a pulp tissue anesthesia, which is by the clock for 15 minutes. Please do not try to enter the pulp chamber before 15 minutes of the anesthesia. And obviously, you're looking at them to be comfortably numb. Obviously, rubber dam, we kept talking, should we? Obviously, pre-COVID area was not possible to use rubber dam in every patient because of the volume of patients, but at least in this COVID area, the rubber dam has become mandatory. So as I say, some things only help us take the positive things. The only thing which we did was previously we were always taught that get the rubber dam below the nose so that the patient had some lesser difficulty to breathe. But this time during the COVID-19, what we started to do is place the rubber dam a little higher than what is actually recommended, so that as to cover the nasal, the nose of the patient, so that in case there is any heavy discharge or any other thing coming out of the nose of the patient, that could be minimized by just placing the rubber dam a slightly higher than what was recommended, is what we followed when we were doing our patients. As far as air rotor, as I told you, we did almost 117 patients under aerosol generation. We were given the option in the guidelines for micromotor versus air rotor. We tried doing it with micromotor, huge vibrations. We tried doing an acute apical abscess with micromotor under local anesthesia. We were aware of this fact that local anesthesias do not have any effect on the proprioceptors as far as local anesthesia is concerned of the periodontal ligament. The vibrations are extremely high as far as the micromotor is concerned. Because of the advantages and the disadvantages of the micromotor, with all the precautions, we preferred to use the air rotor whenever we did the aerosol generating procedures. And obviously, air rotor is to be done with high vac, but we did not have high vac in all of our chairs. So few of the patients, rather major of the patients, had to be ended up doing with a low vac suction. But the message is very clear: if you are using an air rotor, then it has to be an high vac suction. Obviously, as far as as I said, whenever we did our aerosol generation filters, aerosol generation procedures, we had doing it only in the clinics where we had the HEPA 14 filters. And in those clinics where we did not have a HEPA 14 filters, we had standalone HEPA 13 filters. The only thing which I've tried showing in this picture is that the picture onto the left side, please do not place your HEPA filters, HEPA 13 standalone filters behind the dentist. It has to be placed at the level of the mouth of the patient. Now that's the correct position of a HEPA filter. If you have a standalone filter, please never behind the dentist, always at the level of the patient mouth. And that is what the exact position would be as far as that is concerned. As far as obviously, we are really looking at decreased generation of aerosols, least amount of three-way syringe. To the maximum extent, try and substitute your three-way syringe with a cotton pellet. So swap all the excessive moisture or any fluid with a cotton pellet. Please decrease the use of the three-way syringe because that would generate some amount of aerosol. So try and minimize as much as you can. The emphasis was on vital pulp therapy, but you could see that in spite of the emphasis being on vital pulp therapy, by the guidelines and by our own experience, we could not do that many cases of vital pulp therapy. Out of the 117 cases, only 18 odd cases could be done because the irreversible pulpitis cases, not all cases are amenable to vital pulp therapy. But if you have to do a vital pulp therapy, the deciding factor is that after you've done the access opening in an irreversible pulpitis cases, if you can control the bleeding with a sodium hypochlorite pellet, 3% dipped sodium hypochlorite pellet within 5 to 10 minutes, if the bleeding can control, please go ahead with a full pulpotomy. There are many advantages of doing a full MTA pulpotomy. You can see it very, very clearly that this is significantly less time and it is a simple technique and relieves the symptoms very quickly and effectively. So the preferred choice was full pulpotomy with MTA, but only in specific cases where you could get the bleeding control. The other option is please go ahead with single sitting root canals because the more the number of times you're going to call the patient, you're exposing yourself. PPE is going to be utilized for that many number of times. So please try and do either pulpotomies, single sitting pulpotomies or single sitting root canals. Please depend upon a dependable apex locator is what my message is. 2 to 3 months when the apex locators have not been used, our experience with them was whenever we tried using the apex locators, they were showing errors. So please check the batteries back. Please calibrate them back. Please use an apex locator which is dependable because taking an IUP X-ray, no doubt we could take it, but it is an Herculean task wearing those PPE kits. So that's the message, either pulpotomy or single sitting root canals. If single sitting root canals, depend absolutely on your apex locators. If you have to, all cases cannot be done in 2 sitting root canals. What we noticed is that if you have to do 2 sitting root canals, what we experienced in the beginning was that the fillings were getting dislodged. Specifically, if it was a class 2, if we were giving something like an IRM or a CAVIT, the patient was not coming back because of pain, but the patient was coming back because his filling got dislodged. And there was no emergency, but we were obliged to see that patient because we had started his treatment. So what we learned over the period is that please give a glass ionomer holding restoration. Second thing is if you are doing a 2-sitting endo, please call the patient only after 14 days. There is scientific evidence for that is because the incubation period is during that time. So if in case your patient has taken infection from the hospital or during his coming down to your place or anywhere else, at least we would be safer and we would know his test results. So that was the message. If you have to do 2 sittings, let it be with glass ionomer temporization and let the patient be only recalled after 14 days. But we went on to call the patient every 3 days, whoever we treated, just to know about their health status, whether they had developed any symptoms of COVID, yes or no, was a call being sent from our reception to all the patients who were being treated. Obviously, we did not have access to any electronic OPD cards because officially the OPD of the All India Institute is shut. We were only getting through the emergencies, and our computer sections are shut as far as to generate OPD numbers. But the precaution which we took was, one, always handle the OPD cards with gloves. And the second is always use a single pen. Don't mix your pens of the clinic as from your academic side. And we made sure that the pens are also disinfected from time to time. As far as the disinfection of the dental operatory is concerned, as soon as you finish the patient, leave as and where the situation is. Do not do anything. Ask every healthcare worker to leave off the operatory. Come back after 15 minutes, evidence-based. So once you finish your patient, just leave the operatory, try and ventilate it. If you have a window, just open the window, leave your operatory, come back after 15 minutes to clean the operatory, because that's the time the aerosols should have settled down into that area, and you would be in a safer way of cleaning your operatory. How to clean the operatory? I'm sure if somebody would have an question to ask today, would be on this, how to clean the operatory. I'm not too sure. It's been confusing. It's been really confusing how to clean your operatory. The only thing, we tried reading the guidelines. We went back to one guideline to the other. But only thing which we understood is it is the sodium hypochlorite which we are using for cleaning our surfaces. The only thing which I wanted to highlight here is that the hypochlorite, when you are using to clean your surfaces, the amount of sodium hypochlorite onto that surface should be this much that the surface is shiny. If you can see it on the left-hand side photograph, you see it as a visible wet surface. Now that's the amount of sodium hypochlorite you needed. As far as the percentage is concerned, a really tough question to answer. I would go by my society's guidelines. I think this society has done the best thing as far as the guidelines are concerned. I would reiterate, if you are really looking at taking any clue as far as disinfection is concerned, please refer to the Indian Endodontic Society guidelines, which have been made by a very, very powerful group in the sense who have read their work well and made these guidelines. So we're very, very proud that the Indian Endodontic Society guidelines are something which at least we found absolutely doable and to be followed. As far as the percentage is concerned, they're varying from guidelines to guidelines, but the Endodontic Society is clear in 3 percentages for surfaces, for floors, for your tubing. Please go ahead and do this is what I would recommend. Fogging of the dental operatory, we guys have been doing it. We've been doing with something called EcoShield. It has got hydrogen peroxide and a silver nitrate solution. The screen would show you the percentage. Not recommended by any guidelines, not recommended by any guidelines, but we were doing it pre-COVID area. We continue to do it post-COVID area, but not recommended by any guidelines. Not even the CDC, they're not showing us any effectiveness. The WHO guidelines, the new WHO guidelines on the 25th of May also tell us very, very clearly that they have shown no added advantage of fogging with hydrogen peroxide, but we continue to do it for a simple reason. We were doing it before our area which was there. Obviously, this is something which my colleague said must be highlighted, the doffing. We obviously have to have a separate doffing area that is to be there. You have to have the right dustbins to dispose of your thing. Please go down to this link. Please see the AIIMS movie. It has gone step by step. Please be very careful. My colleague told me I must emphasize on this for a simple reason. We've understood that this may be a major source of area of infection among the healthcare workers if they do not follow the right guidelines for doffing. I'm on to the last 3-4 minutes of my presentation. The message here is take care of yourself and healthcare workers. You've got to start your dentistry is my message. You've got to take care of you. I mean, we cannot be foolish during this time, so we've got to take care. What we did at AIIMS was that we had groups. We never exposed the entire group into the clinics. We had a weekly roster, and that weekly roster was a consultant, a senior resident, and a resident, and they only were seeing those patients. The other group was in the office, and then the turns used to change and the other group used to go in. So please do not expose. So if you have two dentists, husband, wife dentists, let one of them practice at one go. If you are a dentist who has comorbidities and cannot practice, employ another dentist, was the answer to one of the questions which I gave. Employ another dentist, at least the revenue start coming in, at least you generate some kind of opportunity for another young dentist is what I would advise you from this. We did regular health updates. So one of my colleagues sends this regular to all my healthcare workers on the third floor, and we get the questions from them. And these are the questions which are noted for them. And if anybody does report that they are not feeling well, the test and rest is what we've been doing. We immediately send them for testing for COVID-19 if they report with any of these symptoms which I previously described. And obviously, till the test results don't come out, quarantine for 7 days is what the DOPT guidelines, the guidelines from the Ministry of Health are telling us. Till the test results of your HCW is not out, please ask them to be staying at home and be safe. Take office message is very, very clear, I think. That is why I said be tactful, be efficient, and be safe. How could you be tactful? You've got to triage your patients as emergencies and urgencies, and the emergencies and the urgencies which were big, the pre-COVID area. Please don't take the post-COVID guidelines as emergencies, because sending your patients back with painkillers and antibiotics are going to get you back. You have to treat the emergency, recognize it. Let those irreversible pulpitis, the pulp necrosis and trauma still be an endodontic emergencies. Please don't send your patients. Obviously, tactfully, we cannot see the same amount of patients. You've got to space your patients. Be efficient. Four-handed dentistry. I think one of my slides got missed. Four-handed dentistry is a must during this time. And I'm sure most of the private practitioners were doing it out here because of the paucity of manpower. We were not doing it. We have now four-handed dentistry. It is increasing the efficacy and less stress, less iatrogenic errors if you do it with a four-handed dentistry during this time. So it becomes almost like mandatory. Utilize the, we did not utilize our junior residents first years or second years, because we seriously felt that the experienced manpower is what is required right now. Emphasize on VPT and single sitting is being efficient and being safe and not being foolish, is to use the right PPE, which is being told to us from time to time, and the disinfection protocols have to be followed. For me, maybe sounding philosophical, I told my team that add another P to the PPEs. PPE is personal protection equipment, add another P, and that is prayers. I think if we do the prayers, somebody's looking after us to save us, and that is what we understood over the period of 2.5 months. Our take is simple. The COVID-19 dental practice guidelines have confused us, have really confused us. One said go this way, the other said go that way, and another one said another way. So the guidelines have been confusing. There is apprehension and anxiety in the minds of our colleagues. My own colleagues, the ones who have been talking, they've been anxious. The anxious, as Dr. Kohli said, was because of the guidelines and the media. The media has done us, maybe sometimes I would say this way, but they were trying to do their duty by telling us what are the numbers and how badly are they increasing. But sometimes too much of media also got onto the wrong side of us, at least the dentists. We are apprehensive and anxious as far as this is concerned. My simple, humble request is just go back to the OSHA guidelines, which were way back 2003, 2008. Just stick to those guidelines. Use a good sterilization equipment. Be careful. Take all your precautions, but you've got to come back to work. OSHA guidelines are there. The CDC guidelines are there, which have been released very, very recently. As Gopi in the morning group said, these are very, very carefully drafted and good, but still they have left the disinfection protocols as confusing, which I thought was the main thing which is needed to be told to the dentist. So if you're really looking at a doable standard operating protocol, I think the Indian Endodontic Society's guidelines are the best in the country. I can vouch for it. Nothing, no agendas here. It's just for the sake of everybody. Please follow the Indian Endodontic Society guidelines. as far as the disinfection is concerned, as far as the classification as emergency, urgency, analgesics, primary and secondary treatment, maybe I have a point of view which may differ in those guidelines. But as far as disinfection is concerned, I did not come across any guidelines which had to be better. The dentists have to decide. We can't keep sitting on the fence. How long are we going to be sitting on the fence? You've got to jump the fence, guys, this way or the other way. And it is better if we jump onto the way, because that would be in the best interest of our profession. We should not be going through the ostrich syndrome. The ostriches are animals who bury their head into the sand and thinking that this problem is going to go away till my head is buried in the sand. It is never going to happen. The COVID is never going to go. This virus is there to stay. So if you think we can bury and stay behind doors and not function at present, may not be the brilliant idea at this stage. Obviously, we're not getting a green signal from the government. We're not getting a green signal to open everything. As Sir said, contamination zones, we don't have a thing, but we don't have to go for the red also. We are not looking at stopping it. The yellow light, as I was told, in any signal, when it is blinking, is meaning that cross, but very, very carefully, very, very carefully. Take your precautions, whichever the government is saying, which are the doable precautions. As I said, no specific precautions more than what the OSHA guidelines was saying, which is not going to be a very difficult thing to do. Follow the yellow blinking light, and I think each one of us has to be safe. I have to thank my team. This team is not to just thank because they were with me for the last 2.5 months, because they believed in the same philosophy, which was the philosophy of the department, that guys, spread the compassion. That's Karuna and not Corona at this stage. We were not looking at doing anything, so the department remained functional, and hopefully the road ahead also is going to be functional for our department. And I think I would stop. Thank you very much. Thank you. And if there is anything which
I need the mic for a few minutes.
Yes, please, sir. Thank you.
Arpit, can I take it?
Yeah, please, sir. Please, sir. Please go ahead.
First of all, I would like to congratulate Ajay Logani for a wonderful presentation.
Thank you, sir.
Not because of presentation, the way he presented, but he was truthful, he was honest to the core. Now I have 1 or 2 questions for Ajay.
Sir.
Ajay, I want to know one thing. I was just noting down, you did 117 cases with aerosol procedures, 247 cases you did.
Yes, sir.
And you have the female doctors, Dr. Amrita, and the doctors in your department also.
Sir.
Definitely. Now this message is for the people, 500 people, those who are listening.
Sir.
Now these doctors were working in a government hospital where they could easily stayed at home, but they have been doing their duty, and they did their duty, and 117 paces aerosol procedure was done, and he was honest. Pre-COVID, they were not using the rubber dam for everyone, because in every webinar you see everyone says, I use the rubber dam and this and blah, blah. Then he was honest. They didn't have all the high suctions. Still they managed. So hats off to them. Now my question to Ajay, to you is, how did you, firstly my question is, did you come across out of 247 any COVID positive patient, or any employee of the hospital getting COVID positive, yes or no?
Sir, thank you very much for the question. And I would be as honest as what I was in during my presentation. My personal view is that first question, very, very 247 patients, we were taking all our things, and we've not come across any 247 patients. But
it is just the history, not the any test.
As I told you, the healthcare workers. So we became more. So it is something which is happening over a period of time. So when the lockdown between March 25th and maybe the first week of April, the movement of the people was very, very restricted. So the patients who were coming in were true emergencies. They had been put in home for, say, 4 weeks. They were already at home for 4 weeks. So we were quite very sure that, and we used to ask them, they used to swear that we haven't moved out. So we did not do any tests. But last 15 days, We've started to at least be very, very careful on our cautioning. And as far as our healthcare workers are concerned, the ones who are coming, the EHS patients, we are making sure that they have a COVID-19 test, because now we are understanding that the HCW are going to become the hotbed for COVID positive. And as far as our concern is, proudly, touch wood, no doctor, but we've had 2 cases of sanitary attendants having come COVID positive in our 3rd floor. Now, so this is something which I need to discuss with you, and the message has to be there. So no doctor, no senior resident, no faculty, no junior resident, no health nursing staff come positive, touch wood for that. Who's coming positive? Who's coming positive? Is these sanitary workers and hospital attendants. So our team in the AIIMS has doing an analysis. They're understanding the people who are using public transport in the last 15 days are the ones who are becoming highly susceptible to be becoming COVID-19 positive.
Right.
So,
now,
yes, sir.
Sorry to interrupt in between.
No, please. No,
I would like to add here, because you are doing the best possible. I believe, what exists and what we can do. We have to choose a way out, as you said, the red and blink and the yellow blink, right?
Yes,
you
sir.
can use the oximeter to check the oxygen level, where
sir.
we can rule out the respiratory patient, anybody is having less than 90% of oxygen concentration, we can segregate them. That can be one of the things which can help. And second thing, what I want to convey to all the people, like I'm being very honest with you, like you did 247 cases. I'm sure if the 500 people are there, they may not have seen for 247 people. Even at this point of time, I'm also looking after the patient. I'm also doing minimum possible, but I'm doing everything.
Very good, sir.
Question out here is, you can't run away from the situation. You have to reset and restart your journey. By sitting home, this COVID is not going to go away. We have to live with it. If we have to live with it, whether you start practice today or you after 1 month, the situation is going to be the same, my dear friends. And you can't live without work. And you cannot be lenient about the precautions, as you very rightly said. Take all the precautions. But whatever maximum you can do, you do. Because the rules, regulations, everything is so confusing. And it causes so much of unrest in the family, in your own mind, when you are not doing anything and just sitting home and doing nothing. So my friends, just reset your life and restart your journey again with proper protocols and precautions. All people are there to guide, like Ajay Logani is there, Gopi Kishan, you can ask anybody. And dentists cannot live without work. And endodontics and oral surgery are the 2 branches, as Ajay said very rightly. And when these people in the government hospital and prime institution, they can do the job, why can't we in practice do little bit to the society? That's my message.
Perfect, sir.
Thank you.
Thank you.
Many thanks to Professor Logani for such a wonderful insight into the practical aspects of managing endodontic emergencies, the AIIMS experience. And many thanks again to Dr. Kohli for elaborating it further. And now it's time for the question and answer session. And maybe we can first take a few questions which are there on the chat box, sir.
Yes, please. And I mean, if sir, whoever can answer, sir can answer, because sometimes maybe sir, whatever. Please.
I'll
yes,
join.
please. Yes,
okay,
please.
so I'll start with the first question. It is about the dependency on the thermal screening, because most of the dental patients must be taking some over-the-counter analgesics and antipyretics. So how effective is this thermal screening as far as dental setups are concerned?
Sir, would I answer or you would answer, sir?
You're talking about scanning?
Yeah, this
thermal scanning.
Yes, sir.
See, again, to be rightly, if the temperature is high, you can avoid taking the patient if it is a temperature, and that's one of the indication he might be a suspected case. But in in the right perspective, as we discussed, each and every patient should be taken as an infected patient and we should take all the protocols. That is the bottom line. But again, coming to the point, as Ajay said, if somebody is irreversible pertussis and he has a fever also, still you have to help him out, whether in the hospital condition or in the clinic condition. Am I right, Ajay?
Yes, sir, please. And absolutely. Arpit, the question answer to that is only for mass screening.
Yeah.
And only for mass screening. You just cannot, by just having the fever, because according to the CDC guidelines, any fever greater than 100.4 degree Fahrenheit is considered as fever for them. And in our country, if you come across a person with 99.4 or 99.6, they don't consider it as fever or febrile. So it's just for mass screening, Arpit, and maybe just for our satisfaction and legality that we did it, because the government is telling us to do it.
So that's the bottom line.
Sometimes you have to be legally correct. And
yeah.
Fine, sir. So coming on to the next one is about the pulse oximeter. Much has been discussed about pulse oximeter, but there is one school of thought which says that most of the patients in our country now are kind of asymptomatic, which are being diagnosed these days. And pulse oximeter will diagnose the partial pressure saturation of oxygen in the blood, and that would only be, that would only be significantly lower when the patient is having some respiratory issues. And by that time, there are many more symptoms which would come up. So how effective is pulse oximeter as a screening tool as far as the private practitioners are concerned?
The pulse oximeter will go the same way as you are doing the community rapid testing. So same way, if somebody is having the underlying condition of the pulmonary disease, and they are more prone to the COVID and all, if the oxygen levels are below 90 or 85, so you can send them to the doctor for the other purpose also, and you can segregate the patient. It is between a normal person or person with the underlying disease. So it's just a screening process, you can say, but you cannot do exactly just because of oxypulsimeter and you don't do the treatment.
Yeah, agreed. That's what sir said is right, absolutely.
Yeah. Logani sir, can I ask you to please stop the sharing of your screen so that we can have more viewers on the view?
Okay.
Yeah. So meanwhile, taking the next question is about the difference in the effectiveness of negative ion generator and HEPA filters. Sir,
anything on this? Because my experience is only what is about HEPA filters, and at least from my theoretical background, CDC has told us about HEPA filters, and the latest guideline says that you can also have standalone HEPA filters. And the only third thing which they told us is the positioning of those HEPA filters.
I'll agree with you what you're saying.
Yeah, yeah. So I have they have categorically said no other method, maybe UV, ion, nothing is required. So maybe there is another angle to it, but the latest CDC guidelines are telling, and for me, it's the HEPA filters, which are in one part of a clinic in our dental center since 2005. And the clinics where we don't have HEPA filters, we have that standalone HEPA filter. So I only told you about where to position it. I don't think so there is anything as far as the other method of ion exchange or anything is concerned. I have no much experience on that.
Thank you, sir, for taking this. Next is about, there has been a guideline which has suggested the use of a table fan behind the operator. So
again, yes, please, sir.
No comments.
No, I have a comment on everything in life. I don't know, it's good or bad, but the thing is, the whole concept is that if you remember the mercury hygiene guidelines also, it said that you always try and make a clinic where the air comes from the side of the waiting room and then into your clinic, and then it goes out into the environment. All right. So in this case also, that at least I understood that they're trying to say that only, that let the air fan be behind you. So you are sitting here, so it comes from here, you're doing some aerosol generating procedure and there is a window in front of you, so it will just pass that way. It won't come back into the patient waiting area or into your clinic. But
Ajay, I will add here, if you have a proper ventilation in the clinic, you don't need all this. If you have a closed building, then yes.
Sir, I would just try and say here, jokes apart, you see, we've had instances where not every person in this country will have the same dental clinic. I mean,
right.
As sir said, that we are blessed to be sitting at All India Institute and having all these facilities, and that is the reason why we could work. And sir's clinic, again, the high end, but then we have clinics where they may not have air conditioning, where they may be in a congested area. For them, just to have a fan, as I said, no evidence onto it, but just trying the loose ends, no harm. A logic, see, and one thing more, out in these type of times when you have nothing, let the logic take place. Yes. Logic says you have a fan behind, you have a dental chair here, you're doing an aerosol, it's just going out. Logic. let it limit to logic. Why are we? Yeah. It seems to be logic to me. So let it be there. Let
it's
it
more
be
of a kind
small,
of a,
huh?
It's more of a common sense guideline, I believe, right?
Yeah.
Common sense for somebody who has nothing, and like sir said, sir is advising everybody to come back to the clinics and with caution. So if somebody has nothing, this small caution could make a difference. No evidence on it, but it could make a difference.
Yeah. Well, coming on to the next question, sorry for rushing a little fast because we have a lot of them. We'll take as much as possible. So next is about the AIIMS protocol of changing PPE after an aerosol generating procedure, because specifically for a private dentist, it matters a lot because there is a cost which is involved, and it's a good.
Ajay, do you change after every patient or every procedure this PPE?
Sir, what we've done is that, as I said, one team goes inside, and each team, so we have 2 senior residents right now and a consultant. So we make the senior resident and both the senior residents wear the PPE at 9 o'clock, and they do 2 patients with that PPE, sir. So your question, is it getting changed after every patient? No, sir. No, sir. It's not getting changed after every patient. Unless or until it gets...
doing any surgery or anything,
unless or until surgery or it is visibly got soiled, sir. It has got visibly got soiled. And I told you that using a rubber dam is like an intraoperative barrier. So the highly infective aerosol. So I read it, and it's my personal belief also, you can actually divide the aerosols into a highly infective aerosol and an aerosol. The highly infective aerosols is the saliva and the blood, and you've actually cordoned that off by putting a rubber dam. So the other aerosol is actually triple distilled water, which is coming into your handpiece, caries, and that's it, enamel. So you're careful. You just be careful.
Nobody can do it after every patient, and
no, he's not doing it. So he does it at 9 o'clock, and 1 o'clock only he does it. Usually 2 patients, but if sometimes the rush is more, 3 patients, then he's done 3 patients. So the answer is no, but that's what we've done, sir. That's what the cost is there. Cost is there. Yes. But guys, the cost is not that much also. We've calculated the cost for level 1 PPE is around 350 rupees. And for level 2 PPE, it's like 850 rupees. With the manufacturing happening in India, and some of the good manufacturing coming with the 63 to 70 GSM suits, the full suits, $800, you'll get everything. So anyway, the cost is going to get transferred.
Another relevant question.
Sir?
How comfortable if one has to work for 6 to 7 hours with the PPE?
Well, how comfortable is, I have done cases myself. I told you that it feels claustrophobic. In spite of the HEPA filters, air conditioning, you sweat. In spite of wearing that mask, your mind sometimes is very blank because of the less of or more of carbon dioxide being generated and being inside your body. So, but there is a learning curve. You get used to working in this learning curve, sir. And I think the sooner people get used to in this learning curve, the more useful it will be for them, because we are looking at practicing dentistry like this as a new normal. So that's my message, sir. New normal is going to be this, and you've got to get used to it. It has a learning curve like anything. So the first day when we wore it, we were like suffocated.
We have to change with the time.
Yeah, it felt suffocated. We feel better now, sir. We got used to it. And those things of, frankly, those things of wearing the PPE once and not being able to even go to the washroom is specifically in COVID-19 areas. We're not dealing with COVID-19 patients. We're seemingly overlapping it. So if somebody does in the same room, then washes his hand and wears a new gloves, and we're still fine with it. Yeah. That's it.
Yes, sir.
Yeah, yes, sir. Now it's a question about nitrile gloves versus latex gloves and UV lights, which are being recommended by many manufacturers.
I'll request Ajay to answer both.
Yeah, so the nitrile gloves are preferred. I won't remember the reason for it. There is a specific reason. Nitrile gloves are preferred. One, they tear less. Okay, so safety is there, and then something has to be there about its wetting properties. So there are two reasons why specifically nitrile gloves are being recommended. As I said, I'm sorry for the second reason, it's slipping my mind. The first is that it tears less. The second is something to do with its wetting property, so that the alcohol based
Few people have allergy to the latex. They wear the
so that is that, but specifically now they are tearing less, and the alcohol rubs, as far as the rub is concerned, is better on to the nitrile gloves. UV lights, forget it, guys. I'm too sure about it. Too sure about it. So when I say I'm sure about it, is because of our not being using it, and the second is the CDC is not telling us. So the Godfather is not telling you to use it. So why? Why listen to it?
It's a marketing strategy by some of the manufacturers, and they are.
Yeah, marketing is.
Yeah, maybe, sir. Maybe. Yeah, I agree.
Coming on to the next question about the Arogya Setu app, what is the AIIMS practice for the patients who are visiting? I mean, is the app being checked for every patient visiting, or how?
At least to my department, my colleague is made sure that whenever the patient comes in, the first question is, do you have an Arogya? No, download it. And then we see his safety. So if it is safe and low risk, and then that one thing is taken care of in addition to those questions. So it's just, again, creating barriers to make sure that everything is safe. And like one of my neurosurgeons colleagues told me, in neurosurgery, they teach them. So it's again learning. So one of the neurosurgery professors, he says, in neurosurgery, in their residency, they teach you to have paranoism. Why do they teach you to have paranoism? Is so that you don't do mistakes. So at the same time, we don't need to be, I'm not saying being paranoid. We're just saying that if you keep doing these things by like an obsessive compulsive disorder thing, that do you have a Setu app? Do you have this? Maybe it becomes a build-up into your thing and you'll create less mistakes. Yeah, that's all.
And is there a practice of refusing treatment to somebody just because he's not ready to download the app, or maybe he has...
I don't think so. I have any instance to it. And the only thing we've done in our center is to identify another place if a COVID-19 patient by chance happens to be needing a dental treatment. So we have a separate room which has been identified as a policy, and it's on the separate floor. And but we haven't refused anybody. I don't think so. It's Arogya could be. You're right. I think. We're not refusing treatment if somebody, I'll ask tomorrow. I haven't had data on that. Maybe, but I'll ask this also, please.
We have some company specific questions about some company products which we won't like to take up on this forum. And we will be taking a question on air conditioners. Sir, what is the AIIMS guideline on air conditioners?
Company you should not take.
Yeah, we are not taking it.
So the air conditioning guidelines are given by AIIMS, and for them, we have the HEPA 14 filters where and if there are no HEPA 14 filters, they have advised us to close the return. Yeah. So I don't know whether I can explain it to you. I'm not a technical person. So the area, so the area where I'm sitting right now is the academic area. Arpit, you've seen it, and even Sir has seen it. And the areas which are in our waiting hall do not have HEPA filters. So the air conditioning is on, but the returns have been closed. And from my point of view, my understanding is that standalone air conditioners, whether split or window ACs, if they're not sharing air with another room, is safe. But you will have to take in the consent of another specialist for this. Yes.
Technical person.
Technical person would be better off. Then please, I may not be the right person.
Sir, coming on to the next question about the anti-retraction walls. Do you have something to say about it?
I mean, all the high-end chairs are coming with anti-retraction walls now, and the J. Morita handpieces also are claiming them. This is there. This is a OSHA guideline, so is nothing new. So if you've not been using it, you've not been practicing dentistry according to the highest safety guidelines, highest safety guidelines till now. So that is what is happening. Suddenly, people are thinking that so many things new. It is actually safety guidelines being given by our organizations for so long. And if you're not using them, obviously the last 20, 25 years, whatever you've been practicing may not have been the right way. Never too late. So yes, a good requirement, a must have.
And I think we are done with all the questions, most of the questions, and rest we have many congratulations messages for Dr. Logani as well as Dr.
Please, thank you. I hope the experience
afterwards, if there are one or two verbal questions, if with the permission of the chair, we can take one or two because we are already overshooting the time.
Arpit,
yes,
we should give the message to all the audience.
Yes, sir.
Reset and restart your life, and go back to your dentistry and help the people, those who need you.
I think, sir, couldn't have been on a better page to have you as the person who was chairing this session and being the chief.
I thoroughly enjoyed. I thought it will be.
The reason is if somebody has a different process, it becomes very difficult to convince people. So nowadays, I have everything. So nowadays, whoever comes to speak to me, I ask the first question, what mindset do you have? Are you the mindset that you want to start, or you are the mindset who doesn't want to start? If the person who is of a mindset not to start, it's like, no use talking.
And gaining the confidence of the patient is very, very important.
Reassurance.
You said is very, very important.
Thank you, sir. Thank
So
you.
happy.
Oh, my pleasure. My pleasure. I'm also very happy.
Thank you, Dr. Gupta.
Thank you. Well, thank you, sir. Just taking 30 seconds more, I invite Dr. Gurusharandi for a vote of thanks.
Thank you.
Good afternoon, everyone. Thank you, Dr. Ajay Gupta, sir, and Dr. Arpit, for giving the opportunity to give the votes of thanks to the chief guest, Dr. Anil Kohli, and also the guest speaker, Dr. Ajay Logani, on the behalf of both the IDA Chandigarh State Branch and ICD. We thank Dr. Anil Kohli, sir, and Dr. Ajay Logani, sir, for an enlightening and entertaining presentation on the right way to manage the endodontic emergencies tactfully, efficiently, and safely during COVID-19. We appreciate having this mysterious area clarified. So your advice to always present an outstanding way to the dentist, showing how to intend the use of protocols for managing the endodontic treatments during this crucial time, and how we'll be able to serve the community is especially useful. So we also want to convey a message to all the youngsters and the budding dentists of today, not to dishearten, instead widen your knowledge and use this time to emerge as a more stronger dentist who is well equipped to tackle all emergencies. Let us help our patients in pain and agony and master the skills of perfect seamless dentistry. And at the end, I would like to convey our gratitude and thanks to each and everyone for being here and participating in the event and taking out their valuable time and utilizing and making this Sunday a super Sunday. We are highly obliged. Once again, we owe you a special vote of thanks for being here, and we really appreciate that and have a small token of our appreciation here for you. Please accept it with a sincere thanks.
Thank you.
That's all from my side. Thank you. Thanks, sir. Thanks, all the participants.
Very sweet. Very sweet. Thank you very much.
Dr. R.P. Gupta has something to say, I think. Dr. R.P. Gupta?
Yes, I just want to say about the ICD. ICD is a honor society and the oldest society of the world. It's celebrating its 100th year in 2020, and this is given to only on invitation to the dentist. The dentist must be very proficient professionally as well as socially. They can apply on our invitation from any old fellows. They can submit their CVs. The CVs will then be scrutinized by peer review group, and then you will be informed accordingly that you are eligible for the fellowship. I kindly request, contact any of our fellows wherever you are. Thank you so much.
Thank you.
With this, we have come to an end of today's session, but a humble request from my side to please share your feedback. And the feedback form is being sent on the live chat. You can just click and a form will open up on your screens, and it is a humble suggestion, humble request rather from my side to please fill the anonymous feedback forms. It will help us to improvise for future webinars. And at the very same time, I want to welcome you for the next webinar, which is on next Sunday, and we will be talking about prosthodontics here, and we will be joined by none other than Professor Hari Prakash, the teachers of teacher, ex-chief CDER-AIIMS, and Dr. Gunjan Pruthi, assistant professor prosthodontics at PGI Chandigarh. And with this, I want to thank the Dr. Mathur wants to speak, I believe. I just received a message. Dr. Mathur, yes. You can unmute yourself.
Yes, can you hear me?
Yes, sir, loud and clear.
Yeah, thank you very much, Dr. Logani. Kohli sir, we are extremely thankful to you for bringing out so many practical points which we were actually thinking what to do, and it made us very clear. I was a very strong critique of whatever the guidelines have come, but today you clarified so many things. Thank you very much, sir.
Thank you.
Congratulations to Team ICD, Team IDA Chandigarh.
Thank you.
Thank you.
And thank you, Arpit, for organizing wonderful webinar.